Do I smell turkey cooking? And cranberries? And mashed potatoes? Or wait, is that just the smell of the oppression of another Native American tribe? Let's go find out. Wait, which way is it coming from? Maybe this guy can help point us in the right direction. Hey, guy! Oh, whoa. Hey, did you know your skin's turning yellow? What's up with that? Oh, you already saw your doctor about it? Hmm. Uh, this sounds interesting. Mind if you give us the whole story? Okay. So, this is White Hummingbird. He's a 68-year-old man who's noticed that his skin has been turning yellow for several months, as have the whites of his eyes. He isn't sure exactly when it started, but he also noticed he became quite itchy around the same time. He also notes he has mild, vague abdominal pain, but has difficulty describing it. He also notes that his clothes have become very loose, making him think he's been losing weight. Further, he states his stool is much lighter in color, almost white, and his urine is dark, dark, dark. He also remembers some of his lab values. AST, ALT, and lipase are normal, but holy guacamole, look at that bilirubin level. Sky high! And ALK Phos is elevated also. I'll bet these labs are big clues. We are asked what the most likely cause is. Well, after watching that last sketch on choledocholithiasis, I'm thinking there's something going on with his biliary system. Not his liver, because his AST and ALT are normal ish. And it's probably not damaging his pancreas either, because his lipase is also normal. Unfortunately, he's losing weight. He's fatigued, and that should wave a big ol' red flag for cancer in your head. So, we're thinking there's a cancer of some sort going on. He's had a few normal colonoscopies, so we can rule out colon cancer. Colon cancer also normally doesn't present with jaundice. Cancer? Biliary tree? Is such a thing even possible? I've never heard of it, but okay. Sure. Let's get started, I guess. It says here that cholangiocarcinoma is a very rare but deadly cancer of the bile ducts, hence the cholangio prefix. Go figure. The overwhelming majority of cholangiocarcinomas are adenocarcinomas, though around 10% may be squamous cell carcinomas. 50% of all cholangiocarcinomas occur at the bifurcation of the common hepatic duct, where they're referred to as Klatskin tumors. Another 40% can be found in the lower biliary tract, below the bifurcation, and finally, the remaining 10% are found within the liver itself, termed intrahepatic. Where the tumor forms has a major role in surgical treatment, which we'll see in a few minutes. Cholangiocarcinoma is most commonly seen in older men, which brings in our first risk factor for cholangiocarcinoma: age. And we need to look no further than our clinical case patient, White Hummingbird, who is 68. The incidence of cholangiocarcinoma increases with age, and most cases are in patients between 50 and 70 years old. Is that a hippo? Aren't hippos from Africa? How the heck do the Native Americans in the 1600s have a totem pole of a hippo? Falsehood, I say. But we'll let that go for the moment. It does serve nicely to illustrate our next idea, though. Hepatitis C is also commonly seen in cases of cholangiocarcinoma and now has been identified as a true risk factor, especially when cirrhosis is also present, causing cholestasis and inflammation of the bile ducts. Hepatitis B is also thought to be a risk factor, but the data is less definitive. In fact, chronic liver disease of any source, including alcoholic cirrhosis and non alcoholic fatty liver disease, is a risk factor for the development of cholangiocarcinoma. The case doesn't dive into all those details, but White Hummingbird does have a handful of beers every night. We should make sure that he's not also developing cirrhosis, but the case doesn't seem to be pointing in that direction. Choledochal cysts, which are most commonly removed in childhood, may also progress to cholangiocarcinoma. The incidence of cholangiocarcinoma in adults with untreated choledochal cystic disease is as high as 30%, hence the whole removing them in childhood thing. While they carry this increased risk, the pathogenesis of choledochal cyst to cholangiocarcinoma is not well understood. While extremely uncommon in the US, hepatolithiasis, yup, stones forming right in the liver, may be present in up to 50% of cases of cholangiocarcinoma in some Asian countries. The exact pathogenesis is unknown, but it's probably due to diet and chronic infection leading to brown pigment stone formation, which leads to obstruction and bile stasis, which leads to inflammation. It's a vicious cycle. Cholelithiasis and cholecystitis have also been shown to have an increased risk of cholangiocarcinoma. However, their main association is with gallbladder cancer. We'll get to that later. An orca totem pole makes much more sense than a hippo. Yeah, I'm still on that. I mean, seriously. It's the same as if they tried to make a giraffe totem pole. Well, maybe they tried, but they didn't have a big enough tree. Well, back to this orca here. You'll also definitely hear about Clonorchis. See what we did there? Orca, Orcus, whatever. Anyways, you'll definitely hear about Clonorchis infection when discussing risk factors for cholangiocarcinoma. And for good reason. Infection with the liver flukes Clonorchis or Opus thorcus causes chronic inflammation of the biliary tree, which, in some cases, can lead to malignant transformation. You may notice a theme developing. Things that cause inflammation of the biliary tree can lead to cholangiocarcinoma. Thorotrasti, an old school radio contrast band in the 60s, also has a clear association with development of cholangiocarcinoma, though it usually occurs 30 years after exposure. So, it's sort of like the worst long con ever. Someone ought to tell Frank Abagnale. Lynch syndrome, the autosomal dominant mutation in DNA mismatch repair genes, is also associated with the development of cholangiocarcinoma. So we've brought in our lynchworm inchworm to remind you. Another associated genetic syndrome is biliary papillomatosis, but it's quite rare. In the US, the most important risk factor for cholangiocarcinoma is primary sclerosing cholangitis, a chronic inflammatory disorder that causes fibrosis and stricture formation in the intra and extrahepatic bile ducts. Let me say that again, because it's important. The most important risk factor for cholangiocarcinoma is PSC. PSC affects men more than women, which may explain the prevalence of cholangiocarcinoma in men over women, and is highly associated with ulcerative colitis. PSC leads to progressive fibrosis of the liver, portal hypertension, and cirrhosis. Cholangiocarcinoma diagnosed in the setting of PSC has an especially poor prognosis, and is usually diagnosed at a much earlier age in these patients as well, as early as 30 to 50 years old. That's not quite on par with our clinical case patient, and he doesn't really have any symptoms that would suggest ulcerative colitis. So, probably not what we're talking about with him. The presenting symptoms of cholangiocarcinoma are exactly what you'd expect from a cancer that blocks bile ducts. Blockage of the bile ducts leads to hyperbilirubinemia and jaundice, pruritus, light, clay colored stools, and abnormally dark urine. Well, geez, our clinical case patient has all four of these. The pathogenesis of these symptoms is covered within our pancreatic cancer sketch. And remember that these symptoms are common with anything obstructing the ducts and aren't specific for cholangiocarcinoma. Okay, so we know something is blocking white hummingbird's bile ducts. How do we make the jump to cancer? Patients may also have constitutional symptoms such as weight loss, malaise, fatigue, or even fever. With regard to fever, while it may exist alone, if additional evidence of infection or sepsis is present, expeditious workup for cholangitis should occur. Dull abdominal pain, particularly of the epigastrum or right upper quadrant, may also be present. However, it's more likely not to be present, with cholangiocarcinoma falling well within the differential diagnosis for the classic painless jaundice presentation. Remembering back to our clinical patient, he has been complaining of some vague abdominal discomfort, so this still fits. On the physical exam, jaundice is the most common finding, with up to 90% of patients presenting with jaundice. And again, this is the case with our clinical patient. Hepatomegaly is also common. A mass may be present in the right upper quadrant, but this is less common than previously thought, with only 10% of patients having a palpable mass. First thing that should be done when working up a patient presenting with jaundice? Liver labs, of course, with special attention to fractionating the bilirubin. With cholangiocarcinoma, expect to see an elevated total bilirubin, which you could probably guess from the jaundice, but with a significant portion being direct bilirubin. Again, our clinical case has a pretty obvious direct hyperbilirubinemia on labs. The increased direct bilirubin is due to blockage of the biliary ducts, i.e., blockage of bile that's already undergone intrahepatic conjugation. The blockage results in reabsorption of the conjugated bilirubin back into the bloodstream. Since cholangiocarcinoma is a primary pathology of the bile ducts, expect to see the alkaline phosphatase elevated as well. And what do you know? That's the case with our clinical patient, too. And unless the tumor is intrahepatic, you should also expect to see AST and ALT levels that are relatively normal. If it is intrahepatic, or if the obstruction has been present for a long time, or chronic, as we say in the biz, AST and ALT could be elevated due to hepatocellular damage. Because alkaline phosphatase can be from a variety of sources, and it may be the only abnormal laboratory value in early cholangiocarcinoma, gamma glutamyl transpeptidase, or GGT, may be used to confirm that the elevated ALK phos is due to a hepatobiliary source. Elevated GGT alone is not sufficient as a diagnosis, as it's also present in a variety of locations. I'll send an SOS to the world. Find someone, yes, message in a bottle. Oh, forgot you guys were still there. My bad. Getting back to where we were. Well, it's kind of like this message in a bottle. Call 199. Carbohydrate antigen 199, aka CA199, is often elevated in cholangiocarcinoma, which may be the body trying to send an SOS to the world. Correct myself up. As with other tumors, elevated CA199 is not diagnostic, but it can play a supporting role in diagnosis. In fact, patients with PSC are often screened at regular intervals with CA199, and elevation should prompt workup for cholangiocarcinoma. Transabdominal ultrasound is performed in most patients presenting with jaundice to look for gallstones, bile duct dilatation, or cirrhosis. While a cholangiocarcinoma might be too small to visualize, intra or extrahepatic duct dilation in the absence of gallstones should raise a red flag for malignant stricture. Distal ductal lesions or pancreatic lesions might be obscured by bowel gas, so abdominal ultrasound is not ideal for identifying lesions here. If nothing is seen, more workup is still warranted. So, this would be a reasonable first step in our patient, but likely wouldn't be able to confirm the diagnosis. In many cases, patients may undergo contrast CT for initial workup instead of ultrasound, or CT may be performed after an ultrasound. CT is useful in these cases because it can show hepatic or pancreatic tumors in addition to bile duct dilatations. Multi detector CT can also be used for more detailed imaging. On either ultrasound or CT, focal bile duct stenosis or evidence of intra or extrahepatic bile duct dilation should prompt more specific and potentially more invasive imaging. Whole abdominal ultrasound and CT may show bile duct stricture and even large masses that can suggest cholangiocarcinoma. However, an important test for diagnosing and evaluating cholangiocarcinoma is MRCP, or magnetic resonance cholangiopancreatography. This imaging technique allows for non invasive, detailed visualization of gallbladder and bile duct anatomy. With MRCP, even very small masses can be visualized. In addition, MRI offers the added benefit of providing essential information for staging and prognosis of the tumor using the TNM system. However, being that it's non invasive, no interventions can be performed if there are obstructions seen. For diagnostic and therapeutic options, patients can undergo ERCP, or endoscopic retrograde cholangiopancreatography. ERCP uses an endoscope to intubate the GI system through the mouth down to the ampulla of Vater. From here, the endoscopist can inject contrast dye into the biliary ducts. This allows for both visual diagnosis and intervention, including obtaining tissue biopsy, removal of obstructing stones, or placement of stents if bile duct obstruction from a tumor is severe. Endoscopic ultrasound, or EUS, is also possible and can be performed at the same time, where an ultrasound probe is used to visualize the tumor through the gastric or duodenal wall. Staging is performed using a combination of these modalities. Unfortunately, cholangiocarcinoma is highly aggressive and usually unresectable at the time of diagnosis. Resectability is determined based on local invasion and presence of metastases. And to make things even worse, surgery is the only option for cure. No chemotherapy regimen has been shown to reduce the tumor size or increase survival. If the tumor is unresectable, stenting by ERCP may be performed as a palliative procedure to decrease hospital length of stay. Palliative stenting may improve symptoms and reduce the risk of some complications, such as cholangitis, improving overall quality of life for the patient. If caught early, however, there are a few surgical options available, and which one is used depends on where the tumor is. The majestic biliary tree. See how its canopy resembles the liver, with the trunk resembling the rest of it. Timber! Whew, man, looks like we gotta chop this liver shaped tree up. We'll use this felled tree to organize our surgical management of cholangiocarcinoma. For intrahepatic tumors, hepatic lobe resection is performed, but the majority of cases are unresectable. Perihilar tumors of the upper one third of the biliary tract, which includes the hilum involving Klatskin tumors, actually have the worst prognosis. Bummer. In these cases, the goal is to resect the tumor with at least a 5 to 10 millimeter margin. Unfortunately, for Klatskin tumors and certain other classifications of tumors, hepatic resection in the form of a lobectomy is also necessary for reduction in the rate of recurrence. For tumors in the middle one third of the biliary tract, resection of the tumor with a 5 to 10 millimeter margin is necessary with reconstruction for biliary drainage again. In both of these cases, since the hepatic duct, gallbladder, and proximal common bile duct are removed during the resection, you have to reattach the biliary system to the enteric system somehow to drain the bile. In comes the ruin why. Hang on to your pilgrimy hats. A portion of the jejunum, represented by this rope, is transected and the distal end is brought up to the liver. The leftover bile ducts are then attached directly to the jejunum, thus draining the bile. The proximal end of the jejunal transection is then anastomosed to the distal jejunal limb, thus restoring GI continuity and bile flow. The whole fancy schmancy name of this surgery is hepaticojejunostomy. Here at Sketchy, we do not condone animal cruelty. No horses were harmed in the making of this sketch. Lastly, if the lower one third is affected, the Whipple procedure, aka a pancreaticoduodenectomy, is the surgical treatment of choice. This removes the lower biliary ducts, gallbladder, duodenum, and part of the pancreas. It's pretty involved. It's pretty awesome. For more technical details, head over to the pancreatic cancer sketch. Overall, cholangiocarcinoma unfortunately has a poor prognosis, as evidenced by this very sad gentleman here. It has a 5-year survival rate of about 15 to 20%, due mostly to high rates of metastasis, vascular invasion, and unresectability. And that sad note finishes up cholangiocarcinoma. Overall, it sounds like we're spot on with our clinical case. The next step for our patient, who has already had labs, would be to get some imaging to determine if it is cholangiocarcinoma, and if so, stage it to determine the next therapeutic options. Moving along the biliary tract, we reach the gallbladder to discuss another rare but serious bad news cancer, gallbladder adenocarcinoma. In the US, gallbladder cancer is quite rare, though prevalence in South American countries is much higher. The most common risk factor for gallbladder cancer is the presence of gallstones, which is thought to cause a chronic inflammatory state that can transform into cancer. Since many of you hearing this probably have or used to have gallstones or know someone with gallstones, don't sweat. Even though gallstones are the most important risk factor for gallbladder cancer, only a fraction of 1% of patients with gallstones will develop cancer. If you have med student syndrome, which is a real thing, by the way, don't worry. You definitely have something else. Chronic inflammation, i.e., chronic cholecystitis, of the gallbladder secondary to stones can lead to calcium accumulation within the gallbladder wall, causing the infamous porcelain gallbladder on imaging. Porcelain gallbladder doesn't mean gallbladder cancer is present, but the risk of developing gallbladder cancer is higher than in patients without porcelain gallbladder. So, to the OR and out with the porcelain gallbladder. Whoa, careful there. That porcelain vase is so fragile. Don't drop it. Gallbladder adenomatous polyps, which are ironically more common in patients without gallstones, are another risk factor. Other honorable mentions for risk factors include primary sclerosing cholangitis, chronic salmonella infection, or biliary cysts. Again, we see the theme of risk factors for gallbladder cancer leading to chronic inflammation, which is thought to lead to malignancy, as we saw earlier with cholangiocarcinoma. Returning to the fact that the prevalence of gallbladder cancer is highest in South America, here's why. There's a high prevalence of salmonella infections, and also cholelithiasis is quite prevalent, but patients are less likely to undergo cholecystectomy than in the US due to socioeconomic factors. This makes the right environment for gallbladder cancer to be more prevalent. Oof, looks like that guy ate some bad stuffing. Good thing his buddy's trying to trade for some medicine for his friend from the Native Americans. Early gallbladder cancer may present identically to biliary colic with right upper quadrant pain, nausea, and vomiting. This is one reason that gallbladder cancer may be diagnosed post-operatively from a cholecystectomy. See, here's proof. The Pilgrims were starving and sick, and the Native Americans helped them out. And how did we repay them? Smallpox blankets. Not a fair trade, IMHO. Like this skinny pilgrim, weight loss and fatigue are symptoms that, if present, should raise the red cancer flag. If allowed to grow enough, gallbladder cancer can cause obstructive jaundice either by growing into the bile ducts, compressing them externally, or by metastasizing into them. A dated, but for some reason still discussed, eponym is Courvoisier's sign, which is a palpable, non tender gallbladder in a jaundiced patient. Back in the day, it was felt to be a hard sign of gallbladder cancer. It's good to know the name, but since it's neither sensitive nor specific for, well, anything, it's not a very good diagnostic indicator. Gallbladder cancer is usually suspected based on findings from ultrasound or CT performed for evaluation for gallstone disease, in which it could show wall thickening and the classic calcification within the gallbladder wall. A mass may also be seen, kinda like these cauliflowers here. Further workup could include additional CT images, PET CT, MRCP, ERCP, and or EUS. We're not getting into those additional details here. However, remember that gallbladder cancer may be diagnosed during cholecystectomy or even after surgery on pathological analysis of the gallbladder specimen. For these patients, further imaging is needed to determine if additional surgery is necessary. Surgery is the only curative treatment for gallbladder cancer and should be performed as an open procedure due to high rates of port site recurrence after laparoscopic resection. Ugh. Alright, while we don't exactly know why it occurs, tumors often recur at the sites where trocars are placed during laparoscopic surgery. Intra-abdominal pressure from pneumoperitoneum, spillage of tumor cells, damage to trocar site tissue, and even just yanking the tumor out through the tiny hole have all been implicated in the development of port site. Point is, some mysterious process may be at work. We don't know why it happens, but it happens. So don't worry about the bikini liner post op recovery. It's cancer surgery. In addition to the gallbladder, a rim of liver tissue and regional nodes are resected as well, aka extended cholecystectomy. As before, gallbladder cancer has an extremely poor prognosis with a 5-year survival rate of about 5%. Bummer. Alright, let's sum things up and get on out of here. Cholangiocarcinoma is adenocarcinoma of the bile ducts. More than 90% are adenocarcinoma. 50% of cholangiocarcinoma occur at the bifurcation of the common hepatic duct, which are termed Klatskin tumors. 40% are below the bifurcation, and 10% are intrahepatic. The risk factors for cholangiocarcinoma include age 50 to 70, hepatitis C, chronic liver disease including cirrhosis, biliary cystic disease, hepatolithiasis, liver fluke infection, clonorchis or opus thorcus, thorotrast exposure, and Lynch syndrome. However, in the US, the most important risk factor for cholangiocarcinoma is primary sclerosing cholangitis, which is strongly associated with ulcerative colitis. Cholangiocarcinoma may present with jaundice, pruritus, light stool, dark urine, weight loss, malaise, and or fever. Abdominal pain may be present, though not always. Rarely a right upper quadrant mass may be palpated on exam. On labs, you're likely to see an elevated direct bilirubin, elevated alkaline phosphatase, but usually a normal AST and ALT unless the tumor is intrahepatic. GGT may also be elevated, which directs the source of the elevated alkaline phosphatase to the hepatobiliary system. CA19-9 may also be elevated, but this is not diagnostic. Imaging workup is usually initiated with either ultrasound or CT, which may show gallstones, dilatation of intra or extrahepatic bile ducts, cirrhosis, or even focal stenosis of the bile ducts. CT additionally may show hepatic or pancreatic tumors. More specific imaging includes MRCP, ERCP, and EUS. Staging requires additional information from these sources. Usually, cholangiocarcinoma is aggressive and detected when the cancer is already unresectable. Palliative bile duct stenting may help alleviate symptoms. If the cholangiocarcinoma is resectable, the type of procedure depends on the location of the tumor. For intrahepatic tumors, hepatic resection is performed. For perihilar tumors of the upper one-third of the bile ducts, including Klatskin tumors, a combination of bile duct resection and hepatic resection is usually performed. For the middle one-third of the biliary system, resection of the tumor is performed, including 5 to 10 millimeter margins of bile duct. For both of these, biliary to GI continuity is reestablished with a hepatico-jejunostomy. Tumors in the lower one third of the biliary system are resected by pancreaticoduodenectomy, aka the Whipple procedure. Cholangiocarcinoma has a very poor prognosis, with a 5-year survival rate of 15 to 20%. Gallbladder cancer, which is very rare in the US, is more prevalent in South America, felt to be due to high incidence of salmonella infections and also socioeconomic factors. The most important risk factor for gallbladder cancer is the presence of gallstones, which is felt to cause gallbladder cancer because of chronic inflammation. Other risk factors include porcelain gallbladder, gallbladder polyps, primary sclerosing cholangitis, salmonella infections, and biliary cysts. Gallbladder cancer may present early on similarly to cholelithiasis with right upper quadrant pain, nausea, and emesis. Constitutional symptoms may also be present, such as weight loss and fatigue. Jaundice may be present if there's compression of the bile ducts, direct extension into the ducts, or metastasis. Workup should include imaging, which may demonstrate calcifications in the gallbladder wall or even an exophytic mass. Treatment is with open cholecystectomy. If identified after cholecystectomy for cholelithiasis, further surgery may be necessary to ensure complete resection and adequate margins. Typically, this involves removing some liver and nodes. As with cholangiocarcinoma, gallbladder cancer has a very poor prognosis, with a 5-year survival rate of only 5%. Well, that's a depressing note to end on. Well, now that they've cut down this tree, maybe they'll let the Native Americans carve another totem pole.